وهنبتدي بالدكتورة غادة السيد من جامعة القاهرة. هتكلمنا عن التايم ترايل. اتفضلي يا فندم.
شكرا جزيلا أستاذ العزيز. Thank you dear professors and colleagues for your kind invitation. Good afternoon. This talk is about the time trial treatment in morning versus evening in hypertensive patients. The protocol of this study was published in the British Medical Journal Open in 2016, and the final results were published in The Lancet October 2022. Before we start talking about the study, we should have some information or some facts that I'm sure you already know, that controlling hypertension reduces the risk of cardiovascular events, and that the blood pressure has diurnal variation with surge of blood pressure early in the morning and a drop of blood pressure in the evening during sleep. Of course, I am talking about normal patients. And that most cardiovascular events occur during this morning surge of blood pressure. Certain studies showed that nocturnal hypertension is a good prognosticator for cardiovascular events and outcomes, and thus studies suggest that giving antihypertensive medication in the evening could reduce the nocturnal blood pressure and thus could reduce the cardiovascular outcomes. Different studies have tested this hypothesis, but the largest was the HYGEIA trial, which was published in the European Heart Journal in 2020. They tested the hypothesis of giving evening dose of antihypertensive medications versus morning dose in more than 20,000 individuals, and they concluded that giving evening doses of antihypertensive medication was successful to reduce the overall cardiovascular events as compared to morning dose. So if we have large-scale study, randomized study as the HYGEIA study, why do we need another trial? First of all, the HYGEIA study was registered to the clinicaltrials.gov in 2008. They published their protocol in 2016, and the time trial published their protocol on 2016 as well. But the investigators of the time trial said that they do not know if any other trials are conducted regarding this issue. Second, that other studies show potential harm to evening doses of antihypertensive medications because of the excessive lowering of blood pressure at night that may lead to falls and fractures, may lead to cerebrovascular events, and may increase the incidence of glaucoma. Other studies also showed that the evening doses of antihypertensive medication reduce adherence among patients. In addition, the HYGEIA trial faced a lot of criticism as regards the randomization, criticism as regards why they did not terminate the study, because the HYGEIA trial showed marked a preference of the evening doses with 40 to 50% reduction of all cause mortality and the cardiovascular mortality. In addition, the HYGEIA trial showed that 40% of non-cardiac mortality was reduced with the use of evening dose, and this was not explained by the trial. That's why the aim of the time trial was to investigate whether the evening dose of antihypertensive medication is capable or is better than morning dose in reducing the overall cardiovascular outcomes, namely the vascular death, the hospitalization for non-fatal MI, and the hospitalization for stroke. This is the study design. The study design is a prospective study. It is a pragmatic study as opposed to the randomized trial. It's a study based on the clinical practice. It is a study which included heterogeneous group of patients, but it imitates real-life situations. The study was a decentralized study, means that they did not meet the patient. They contact the patients through telemedicine, through emails and phone calls. And it's a parallel group study, meaning that they give they randomize patient to morning doses versus evening doses at the same time. It's an open label study, means that the patient and the investigator knows exactly which patient is taking morning doses versus evening doses. It's a blinded endpoint. There were blinded investigators to analyze the endpoints, and it's a superiority study, meaning that they are seeking for superiority of evening doses over morning doses. Which patients were included? Patients with known hypertension, treated hypertension taking more than at least one antihypertensive medication at one time, once daily, and they should have valid email address and they should be electronically literate. And excluded from the study are night shift workers and patients taking more than one dose of antihypertensive medication. The study was conducted in the United Kingdom through retrieval of data from the National Health Service primary care practice. There was a pilot study starts in 2011 till 2014 to test for the feasibility of the time trial, and then they started recruiting the patient for the full study in 2014 till 2017, and they continued follow-up till 2021 with a median follow-up period of 5.2 years. How did they do the study? They randomized patients on one-to-one basis, either to morning dose of antihypertensive medication between 6 and 10 a.m., or to an evening dose between 8 p.m. and midnight. Then they contacted the patients through online study portal and through emails. They asked the patient to fill questionnaires every 3 months, and through these questionnaires, they tested the patient's adherence to medications, the occurrence of pre-specified side effects, or the occurrence of potential endpoints. At the start of the study, they asked patients whether they have home blood pressure monitors or not, and those who had blood pressure monitors, by the way, they were about 50% of patients included in the study, they were asked to measure the morning and the evening blood pressures at least for 4 to 7 days, and to submit the measurements of blood pressure to the study portal online. This is the follow-up form, and patient, of course, logs in this study form and fills in all these checkboxes every 3 months. So what they were searching for safety issues like falls or fractures, dizziness, upset stomach or indigestion, muscle aches, and the primary outcomes, as we said, the composite of vascular death, hospitalizations for non-fatal MI or non-fatal stroke, and the primary outcome was time to first event. While the secondary outcomes were the individual events, vascular death, non-fatal MI, non-fatal stroke, hospitalization or death from congestive heart failure, patients' adherence to medication, and patients' pre-specified side effects. And then they analyzed the results according to the subgroups, according to age, body mass index, occurrence of previous heart disease or stroke, diabetes, or antihypertensive medications. So they screened 24,600 patients, and after putting eligibility criteria, more than 21,000 patients were randomly assigned to treatment groups, 10,503 to the evening dose and 10,601 to the morning dose. When they compared both groups, according to baseline characteristics and cardiovascular risk profiles, they were similar, they were comparable. And when they compared, they followed up the patient, of course, and the median follow-up, as we said, was 5.2 years. They discovered that there was no statistically significant difference between both groups as regards the primary and the secondary endpoints, yet the evening dose group was numerically less than the morning dose group as regards the primary composite endpoint, the hospitalization, the individual hospitalization for non-fatal MI, non-fatal stroke, and the hospitalization or death from congestive heart failure. This is the cumulative hazard along the follow-up years of the study. The longest duration was 9 years, and they discovered that the unadjusted hazard ratio was 0.95 with a p-value of 0.53, so there was no difference between both study groups according to the time to occurrence of first events, and by the way, the median time to occurrence to first events was 1.7 years. This is a subgroup analysis. As you can see here, this is the first plot. All subgroup analyses crosses the line of unity, and thus there was no difference between groups as regard different subgroups. When they analyzed the side effects, they found that patients who were taking morning dosing had numerically higher, but not statistically significantly higher, dizziness or lightheadedness, GIT problems, diarrhea, feeling generally unwell, and muscle aches. They found that patients who were taking evening doses had more incidence of non-adherence to randomized dosing time, and they explained this difference in the value because most patients who pre-specified their antihypertensive medication before starting the study as morning dose. So these patients were asked to change their antihypertensive dosing regimen to evening doses. Patients got confused, they got forgetful, they got upset because of the changing of the times, and thus they returned back to their morning doses. Also, patients who were taking evening doses, who were taking diuretics had a higher incidence of changing the dose from evening to morning because diuretic caused them to go to have interrupted sleep and to go to the bathroom many times during night. But patients with morning doses had higher incidence or marginal significant falls and higher glaucoma requiring hospital admission against all odds that says that evening dose increase the incidence of glaucoma. Patients who had home blood pressure monitoring, who submitted their blood pressure measurements, it was shown that morning assessed the blood pressure was better in patients taking evening dose antihypertensive medication, while the evening assessed blood pressure was better in patients taking morning doses of antihypertensive medication. 11.6 patients were withdrawn from the questionnaire follow-up. 2/3 of these patients were in the evening dosing group, as we said, because of changing the schedule of their antihypertensive medication, and 4% of patients, they withdrew their consent for medical records. So they concluded that evening dosing of antihypertensive medication did not improve the primary composite endpoint, and they recommended that antihypertensive therapy be taken either in the morning or in the evening according to patient's preference. But this is not the end of the story. This study has many limitations. It's an open label design, thus it may affect the patient's behavior and the reporting because the study is based mainly on patient reporting. The side effects are participant reported, and thus it is subjected to incomplete and recall and the reporting bias. Higher rates of withdrawal, 11.6 is high rate of withdrawal, thus they may lead to underestimation of actual adverse events. The home blood pressure being submitted manually by participants, so it is susceptible to recall bias and data entry errors, plus the higher incidence of non-adherence to antihypertensive schedule in the evening group, as we said, because pre-study most patients had their drugs in the morning. This leaves us with the question, are we happy with generalizing the results of this study to our patients, taking into account the limitations of this study and taking into account the profile of patients? The study participants are patients who are educated and more health aware. They should be electronic information literate. They should have valid email addresses. And that participants were voluntary participants. That means that they have more positive health behaviors and that the study is questionnaire-based study. It's a totally subjective study. It does not depend on office or ambulatory blood pressure measurements. Thus, we should think twice before generalizing the results of this study. In addition, there are still unreported data as regards the sleep quality, the cognitive functions, the mood, and the chronotype of patients. Thank you.
شكرا. هو طبعا هو سؤال وجيه، يعني الستادي ادريسنج حاجه له راشونال فعلا، بالذات حكايه المورنينج سيرج، ففي راشونال للموضوع، والموضوع يستحق فعلا اعاده النظر يعني. وداخل فيه كمان غير الديبنج والنون ديبنج، الناس اللي بيحصل لهم فاريابيليتي بلاد بريشر غير الديبنج والديبنج، فاريابيليتي في بلاد بريشر ات هوم فيرسس اوت اوف هوم، او في الديلي لايف فيرسس باي نايت. فالفاينل كويستشن او الانسر اوف ذا فاينل انسر از نوت يت ذير يعني.
يس.
شكرا. في اي حد يسال؟ ثانك يو فيري ماتش.
شكرا.
Next speaker will be Professor Dr. Magdi Abdelhamid. He will. Dr. Hussam Al-Arabi will speak about the FRAME AMI trial.
ولا يهمك. طبعا بشكر دكتور مجدي على الدعوة وعلى الايفنت القوي والبرنامج العلمي المحترم اللي احنا شايفينه. يمكن دي اخر سيشن، والسيشن دي الحقيقة بتدسكاس 3 very important new trials. 4 تقريبا، هم مش 3 مش كده؟ 4 new very important trials الحقيقة. واحدة منهم اللي أنا هتكلم عليها اللي هي الفريم acute myocardial infarction trial FFR guided PCI in patients with myocardial infarction and multivessel disease is superior to angiography guided PCI. This is the question of the study. The study was announced in the last European Society of Cardiology meeting in Barcelona in August. The most important point in this study is it is an investigator-initiated trial. It is not a company-sponsored trial, and a grant was taken from several pharmaceutical companies: Medtronic, Biotronik, a Chinese company, and JW Pharmaceutical Company. Several companies funded this trial, so it is not sponsored by a specific company. It is an investigator-initiated trial, and this gives a strong point to the trial. To start with, the 2012 guidelines, the European Society of Cardiology guidelines, was stating that PCI in non-culprit vessels in acute myocardial infarction is generally discouraged. It was contraindicated at this time. And the American Society of Cardiology 2013 was the same, class 3 indication. PCI should not be performed in non-infarcted artery at the time of primary PCI in patients with STEMI who are hemodynamically stable. وكان الانديكيشن في الشوكت individuals ان هم دول اللي يتعمل لهم PCI. الكلام ده كله اتقلب بعد كده. برامي ترايل اللي اتنشرت في 2013 وضحت لنا انه preventive PCI معناه same setting immediate PCI for non-infarct related artery. العيان بيعمل primary PCI وبيتعمل randomization immediate والعيان على الترابيزه، وجروب كان بيتعمل له preventive PCI للنون culprit arteries اللي فيهم more than 50% stenosis، وجروب تاني كان بيتعمل لهم postponing بعد ما بيخرج بيتعمل لهم planning للأذر vessels. وكان في relative risk reduction رهيب 65% compared لل no preventive PCI. فده كان مفاجأة كبيرة في 2013، ودي اتنشرت في نيو انجلاند جورنال اوف ميديسن. برامي ترايل دي كانت ترايل مهمة غيرت الكونسبت في البرايمري PCI. بعد كده ظهرت ترايل تانية اسمها كالبريت ترايل بعديها بسنتين، واتنشرت في الجورنال اوف امريكان كوليج اوف كارديولوجي، وكان نفس القصة انه بيتعمل complete or incomplete revascularization. بس الفكرة بقى كانت the same admission، يعني كان staged، بس العيان قبل ما يخرج من المستشفى يكمل ال non-infarct related artery. وكان الفرق زي ما احنا شايفين كبير برضو 55% relative risk reduction زي ما احنا شايفين في الصورة اللي قدامنا. وده خلى الامريكان جايد لاينز غيرت ريكومنديشن لكلاس 2A PCI should be performed in non-infarct related artery at the time of primary PCI in patients with STEMI who are hemodynamically stable. The same setting زي البريما ترايل ما بتقول. اليوروبيان بقى خدت الفكرة بتاعت الكالبريت وقالت انه روتين revascularization of non-infarct related artery should be برضو class 2A in STEMI patients with multiple disease before hospital discharge. ده الكونسبت بتاع الكالبريت ترايل. يعني الامريكان same setting، اليوروبيان قبل عام ما يروح تكمل الاذر فيسز مش ذا سيم سيتي. فدي 2017 اليوروبيان جايد لاينز، والكلام ده لحد دلوقتي ما اتغيرش. واحنا عارفين كالبريت شوك قالت انه في وجود الكارديوجينيك شوك كالبريت اونلي ما عملش الاذر فيسز، عكس كل الكلام اللي كان بيتعمل في 2012 و2013. الباك جراوند بتاعت الترايل دي in patients with acute myocardial infarction and multivessel coronary artery disease percutaneous coronary intervention of non-infarct related artery lesions for complete revascularization improves the clinical outcome. However, optimal strategy to select targets for non-infarct related artery PCI has to be clarified. The objective to compare fractional free flow reserve guided PCI with angiographic guided PCI in non-infarct-related artery among patients with acute myocardial infarction and multi-vessel disease. The hypothesis of this اللي هم مفترضين وعايزين يثبتوها ان selective PCI guided by FFR is superior to routine PCI guided by angiography alone for treatment of non-infarct-related artery in patients with acute myocardial infarction and multi-vessel disease. الهايبوثيسيس كانت superiority، هم بيتست superiority. والinclusion criteria for these patients more than or equal 19 years old with STEMI or non-STEMI, both, with successful primary or urgent PCI to infarct-related artery, at least one non-infarct-related artery with diameter stenosis more than 50% in major epicardial coronary artery or major side branch with a vessel diameter more than or equal 2 millimeters by visual estimation amenable for PCI. هم دول اللي هيدخلوا. Exclusion criteria: single vessel disease، يعني ما فيش other vessels to be treated. Target lesion located in the left main، the exclusion. Cardiogenic shock exclusion. Chronic total occlusion in non-infarct-related artery. This is the fourth exclusion of this trial. This was the design of the study. After primary PCI, the study was performed in 14 sites in Korea. Patients with acute myocardial infarction, multi-vessel disease. After culprit vessel PCI, randomization was done to FFR-guided revascularization. If FFR showed the lesion it's less than or equal 80, so PCI is performed. More than 80, so it is postponed. Angio-guided, any patients with a diameter stenosis more than 50% angiographically by visual estimation should do PCI immediately on table. And endpoints were composite death, myocardial infarction, repeat revascularization, primary endpoint, and several secondary endpoints, as you see here. The calculated sample size was 1,292 patients to provide 90% power at two-sided type of error 5%. Unfortunately, because of COVID-19, the study was unable to continue. During this study period, COVID-19 pandemic occurred and enrollment became substantially slow. The incidence of hospitalization for acute myocardial infarction decreased globally by as much as 50% during the pandemic. The patients were afraid of going to hospitals. Several centers halted the trial due to temporary unavailability of facilities, lack of personnel, and concerns about the spread of COVID-19 shifted to thrombolytic therapy in many hospitals. December 2020, the executive committee made the decision to terminate the trial early because of difficulty in recruitment and scheduled follow-up for the patients who were already enrolled in the trial. So the study didn't reach the target number assigned by sample size calculation. So from these patients, 284 were randomized to FFR guided and 278 to angiographic guided. Even after randomization, some patients were excluded because of protocol violations. After randomization, the operator didn't obey the randomization، اشتغل بدماغه، فدول طبعا excluded. وصلنا ل 284 في ال FFR group و 278 في ال angio group. والbaseline criteria was the same regarding the risk factors: previous myocardial infarction, previous stroke, ejection fraction, whatever STEMI was the same. STEMI was 46 to 48. Non-STEMI, the same. Discharge medications were the same between the two groups. The location of infarction, LAD, circumflex, right coronary, the same. Radial axis, most of the patients the same between the two groups. Thrombus aspiration, about 1/5 of the patients in both groups. The same for glycoprotein B3 antagonists. Drug-eluting stents for most of the patients. Intravascular imaging in nearly 1/5 of the patients. Mean stent diameter 3 and total length 36 to 34. As you see, the timing of infarct-related artery immediately or staged immediately in 60% of patients in both groups nearly, and staged before discharge in 40%. Comparable baseline criteria, and the primary endpoints of the study were in favor of FFR-guided PCI, as you see here, with a relative risk reduction that's huge, about 57% compared to angiographic-guided PCI. So it is a positive trial, but with less power. Most of this difference was due to cardiac death, which was 1.4% in FFR guided compared to 8.2 in angiographic guided. 3 patients versus 15 patients. Usually in a small number of patients, such differences become magnified. So this is a limitation of the study despite the positive results. The procedure-related myocardial infarction with the reverse, with higher in angiographic guided compared to FFR guided PCI. And these are the 2 influential factors that affected the outcome in this trial. When you look to subgroup analysis, no difference regarding whether the patient did immediate PCI or staged revascularization, whether non-infarct related artery involved with the LAD or not, the presentation is STEMI or NSTEMI, no difference. Males versus females, no difference. Age, more than 65 or less than 55, no difference. Presence or absence of diabetes, ejection fraction, less or more than 50%. The type of P2Y12 inhibitor, whether clopidogrel, ticagrelor, or prasugrel, no difference between the subgroups in subgroup analysis. When you look to the composite of, as a second endpoint, death with spontaneous myocardial infarction or repeat revascularization, there was a relative risk reduction of 56%, a large difference between the 2 groups. The limitations, as we said, given the observed event rates, ARMY termination affected the results. Actually, the mean follow-up duration and the number of enrolled patients, the actual power of the trial to show the difference in the primary endpoint in the 2 groups should be 95%. Both STEMI and non-STEMI patients with multivessel disease were evaluated in the present study, and we know these are 2 different diseases completely with 2 different prognoses, so it is wrong to consider both in the same study. The conclusion, among patients with acute myocardial infarction and multivessel disease, a strategy to selective PCI using FFR-guided decision-making was superior to a strategy of routine PCI based on angiographic diameter stenosis for the treatment of non-infarcted left artery lesions regarding a composite of death, MI, or repeated revascularization. Thank you very much.
Thank you, Professor Hussam, for this elegant presentation. I'd like to ask a question about the one limitation that was maybe not addressed in this presentation, the use of FFR in the acute setting of myocardial infarction. Is it a limitation? Is it a real limitation for this study?
No,
not IFR?
This is a limitation if we use it in infarct-related artery. We don't use it in infarct-related artery, we use it in non-infarct-related artery. So this is not a limitation here.
So what is the suggested practice for us, for all the audience? What is your suggestion for dealing with patients with multivessel disease and myocardial infarction, even STEMI or non-STEMI? Only or staging of the procedure?
Actually, the more practical in Egypt to go for complete revascularization. Because of the administrative logistics, it is better to do all the vessels to the patient in the setting of acute myocardial infarction unless the patient is in cardiogenic shock, and we have to adopt this. We have a problem in some of the funding places to do this, but we have to change the concept to be with the guidelines.
Maybe another exception, patient with impaired renal functions, we don't want to use much dye. maybe in this برضه the amount of dye we use during the procedure if we exceed it.
Actually, we can suggest this, but we don't have data to support this. But it's logic. Patients with impaired kidney function should do PCI with the least amount of contrast in the acute setting. So in fact, the lateral artery PCI could be better, but we don't have an evidence to support this till now from the literature.
Thank you, Dr. Hussam.
شكراً.
I think we have another questions. Thank you.
نيكست سبيكر استاذ الدكتور احمد سمير هيكلمنا على الريسنت كلينيكال ستادي ريفايفد. دكتور احمد سمير موجود؟ اتفضل اتفضل يا فندم.
السلام عليكم بس مدرس بس. Revived BCIS2 and some surprises so that we will go through inshallah. First, it is subjected to the percutaneous revascularization for ischemic left ventricular dysfunction or ischemic cardiomyopathy. And BCIS2 stands for the British coronary intervention scoring, assessing the Jeopardy burden or the extent of coronary artery disease. What we know about the subject, where were the gaps in evidence related to that very hot subject, and what did Revived answer, and what questions remain, this is the agenda of my presentation, inshallah. What we know about it. The consecutive versions of European Society of Cardiology myocardial revascularization guidelines have stated through decades that among the indications for survival, revascularization targeting survival in CCS patients, to have a patient with ejection fraction of 35% or less, with 2 or 3 vessel disease with more than 50% and a demonstrable reversible ischemia. And for long, this has not been changed in the myocardial revascularization guidelines in the 2014 version, 2018 version, taking a class of recommendation 1 and a level of evidence A. However, same society, European Society of Cardiology, when it was talking about the perspectives from the heart failure point of view, have stated that for patients with HFrEF, CABG should always be the first option for revascularization. PCI is classed to be as an alternative. And if we went to the box above, the last one I have referred to, revascularization to relieve persistent symptoms of angina takes the class 2A, while if this is related to improvement of survival in HFrEF patients, this takes the class 2B. So we have now a differentiation between talking about the perspectives for the myocardial revascularization and defeating the coronary ischemia side, and improvement of the heart failure manifestations and the cardiomyopathy side. So the gaps was essentially raised after the ischemia trial, and particularly after the 5 years data from the ischemia trial, because it started to question the additive benefit of PCI over optimal medical therapy alone in patients with CCS when we consider improvement of survival. Nevertheless, ischemia did not touch this special cohort of patients because ejection fraction of less than 35 was an exclusion criterion. However, the hibernating myocardium dogma, which was there and rising through the past 2 or 3 decades, was now translating into confusion. Is it myth or reality? Stitch trial on the other side, which randomized more than 2,000 patients for CABG versus optimal medical therapy, included selectively patients with ischemic cardiomyopathy, ejection fraction 35%, so it is more or less the same cohort. However, it was excluding patients with left main disease and patients with previous CABG. We have found that CABG as a modality for revascularization, yes, it is bloody effective. However, it has a large toll to pay because we have found and seen that in a 30 days mortality assessment, CABG led to 4-fold rise in 30 days mortality compared to optimal medical therapy alone. All-cause mortality, when assessed at the end of the study, the end of the first stage of the STITCH trial, it was equivalent at 5 years. And mind you, we will need to go back to these figures, 28% versus 33% at 5 years. And by 10 years, when the second stage of STITCH trial was revisited, we have seen that the curves separated significantly, denoting improved survival in CABG candidates compared to optimal medical therapy alone. However, we have to again re-mention that in both arms of the STITCH trial, CABG or optimal medical therapy alone, just having viable myocardium at baseline resulted in improved long-term survival in both arms by a risk reduction or a relative risk of nearly 30%, which means that patients with viable myocardium when receiving optimal medical therapy alone had much better survival than those assigned to optimal medical therapy without viability, and same when surgical revascularization was opted for. The benefit of CABG plus optimal medical therapy versus optimal medical therapy alone on all-cause mortality was decreasing with age, which means that the primary endpoint was increasing significantly as we go more in the stratum of age blotting. So what did REVIVED answer for this? Because revived PCIS came to fill a particular gap in evidence, selectively including patients with ischemic cardiomyopathy, LV dysfunction with ejection fraction less than 35%, considerable residual viability, and anatomy that is amenable for PCI. The study aimed to test whether PCI would add incremental prognostic benefit over optimal medical therapy alone, particularly after what we have seen the revolution in heart failure therapy in these 2 decades that we have seen. It randomized 700 eligible patients with ischemic cardiomyopathy across 14 centers in UK, 1-to-1 randomization. The primary endpoint was the composite of all-cause death or hospitalization for heart failure. The secondary endpoints were looking at ejection fraction at 6 months, 12 months, and individual primary outcomes of the composite and the quality of life. The follow-up was a median of 3.4 years. The inclusion criteria, as we have mentioned, 35% ejection fraction or less, extensive coronary artery disease, viability, and amenable for PCI anatomy. And they have excluded acute myocardial infarction within 4 weeks, acute decompensated heart failure, and sustained ventricular arrhythmias within 72 hours before randomization. The baseline features were more or less similar between the 2 groups, but the age of the cohort that was recruited in the study was pretty biased towards what we say the 8th decade. It was 70 plus. They did not exclude patients with prior CABG. Yes, these are a very small number of patients, but we know all that revascularizing patients after failed surgical grafts is not like the common pool patients with ischemic cardiomyopathy. They have recruited patients with no or minimal angina at baseline. Patients with angina class 3 were 2% in each arm. And this was, again, because they did not exclude left main disease. Regarding the principal findings, they have shown that the primary outcome occurred in 37% versus 38% in PCI versus optimal medical therapy alone. And I guess everybody in the whole here thinks that this is a pretty high figure for the modern management of HFrEF in 2022. And we will come back to this. Also, they have seen that the death from any cause was the primary driver and the primary outcome, while hospitalization occurred in almost 1/3, and these are not additives. A patient might have been hospitalized for heart failure more than once, then he died through the study period. It is not an exclusive endpoint. Acute myocardial infarction occurred in 10% versus 10% or 10.7, 10.8%. However, the majority or a big sum of the myocardial infarctions in the PCI side was the peri-procedural phenotype and unplanned revascularization, which means that a patient randomized for optimal medical therapy. In the middle of the study, duration was mandated to have revascularization. This occurred in almost 11%. And mind you that among these, almost 80% were revascularized by PCI, while only 20% by CABG. So, the secondary outcomes, we all know that it did not differ ejection fraction, and they have mentioned also that the quality of life assessed by Kansas City Cardiomyopathy Questionnaire, there was an improvement in the quality of life at 6 months, at 12 months. However, there was a catch-up by 24 months where when the optimal medical therapy started to get its fruit, patients assigned to optimal medical therapy had almost the same improved quality of life, similarly as their PCI counterparts. And in the subgroup analysis, as we can imagine, younger patients benefited more from PCI. Patients with larger jeopardy ischemic burden or more extensive coronary artery disease benefited more from PCI or from revascularization. Patients with lower ejection fraction benefited more. However, these findings were all numerical and none of them was significant. Is that everything, or remains any questions that we can dig around after the revived PCIS? Actually, I guess there are some devil in the details that we can have. When we go deeper into the primary outcome, the composite of all-cause death occurred in 37% versus 38%. Mind you, the figure that we have seen in Stitch after 5 years, it was far less than this. It was 28 and 32. Why that high rate of death has happened in the revived PCIS? It is not attributed for decompensating heart failure or worsening heart failure, because actually the heart failure was counting minimal through this large number. And actually same with acute myocardial infarction. These patients did not die for decompensating heart failure or for acute myocardial infarctions, particularly respecting that like 50% of the myocardial infarctions in the PCI group was the peri-procedural type. And actually 40%, which is one thing more, of the cohort merged almost evenly between both arms, have defibrillators implanted within less than 90 days of recruitment. So any sudden cardiac death could have been aborted in almost half the study group. So what was the primary driver for all-cause death if it is not MI or ADHF? Was it due to lots of non-cardiovascular comorbidities limiting the overall survival of the whole study group in both arms, or because the threshold to hospitalized acute decompensated heart failure was too conservative, or because there was many undiagnosed, unreported acute coronary syndrome that were not taken as direct cause of death? I don't know, and obviously it was not very clarified in the study. What we can see more that Stitch enrolled patients with and without demonstrable viability. And we have seen at 10 years that the viability was an independent predictor for improved outcomes in both arms. So after 2 decades of time, with ARNIs and SGLT2 on board, and besides the device therapy, and in a 70-year-old English cohort who are entertained with the NHS and a very solid, rigorous health system, I do not feel that this 37-38% of death is pretty justified if these were the ordinary patients that we are seeing every day in our practice. Rates of malignant arrhythmias. In the 40% patients who have been with an ICD, it was dramatically dropped with a significant change, a significant difference between those with PCI versus those with optimal medical therapy, with a risk ratio of 0.42 at 24 months. This was very marginally significant. The quality of life. We essentially focused on heart failure aspect with the Kansas City questionnaire. we would certainly be of value to whether the assessment of angina improvement at such a cohort with ischemic cardiomyopathy, but this was totally ignored and excluded from the investigators. No wonder that in terms of heart failure-related questionnaire, there was a catch-up at 24 months, but this could have been different if angina was taken into consideration. My last 10 important takes from the revived PCIS that it is a critically needed block in the management of ischemic cardiomyopathy, selectively recruiting patients with ejection fraction with less than 35%, demonstrable viability, significant coronary artery disease that is amenable for PCI, and a good design funded by NIH away from the industry. Important consideration that these 700 patients were English cohort. For a 70 years English guy, he is usually healthy and live. He is privileged with a solid and a powerful national health system, but we do not have any data about the comorbidity of the frailty scores for these patients. In such a solid health system through the recruitment years, one can imagine that the majority of that profile, ischemic cardiomyopathy, amenable anatomy for PCI, and viability, they should have been directed or advised for CABG. But this is, again, questioning if those leftover non-operated patients who were recruited to revive had high comorbidity burden, elevated their surgical risk, or maybe a coronary anatomy with extensive diffuse distal disease, rendering them not the best candidates for surgery, particularly when we find that when the 10.5 crossed over from the optimal medical therapy towards the PCI group or the revascularization group, the unplanned revascularization was carried on with 80% PCI, 20% CABG. Contrary to STITCH trial, neither prior CABG nor an estimated longevity threshold like 3 years, for example, which was the cutoff in the criteria for eligibility for STITCH, were considered for the revived PCIS. Despite more than 2 decades through which HFrEF management was revolutionized, revived in 2 years had nearly similar or actually more all-cause death rates to what we have seen in STITCH after 5 years. Moreover, STITCH included those with and without viability, and lately concluded that there was significant impact of viability in patient survival in both CABG or optimal medical therapy. One could have expected to see a figure that is less than that of STITCH in revived PCIs. This is a big question that is not answered. And despite a comparable rate of any myocardial infarction between both arms, a large subset of acute myocardial infarction in the PCI group were of the peri-procedural type. It was like 50%. And when we look only towards the spontaneous MI, it was hit in 48.7 versus 86.8 in the PCI versus optimal medical therapy. They did not go for statistics for this, but actually the risk reduction, if we count it manually for these figures, it is 0.45 in favor of PCI. Among the non-highlighted results, that PCI led to significantly fewer unplanned revascularization with a significant risk reduction, fewer aborted sudden cardiac death events with a very marginal significant risk reduction. Quality of life assessment was mainly focusing on heart failure-related parameters and totally ignored angina. In the subgroup analysis, there was no reference to the differential benefit according to the percent of revascularization completeness. They have mentioned that the average completeness percent in the PCI cohort was 71%, which means some of the patients have been revascularized with completeness of 100%, and others maybe were approaching towards 50%. This should have been a good parameter to see the subgroup analysis around it. And lastly, it took 10 years to appreciate the benefit of CABG over optimal medical therapy in ischemic cardiomyopathy in STITCH. No one knows the surprises the coming years hold for us. Thank you.
Any question, Dr. Ahmed Samir? شكرا دكتور أحمد. شكرا جزيلا.
Much.
مسك الختام بقى عندنا أستاذ دكتور مجدي اتكلمنا على ديليفر ستادي.
عارف ان طبعا الناس بعد الساعة 5 خلاص يعني تعبانين وعايزين يتفرجوا على الماتش. I will take just 10 minutes maximum to talk about one of the important trials which have been presented in the last ESC meeting in Barcelona which is dapagliflozin heart failure with mildly reduced or preserved ejection fraction, which is the DELIVER trial. We know that SGLT2 inhibitors reduce morbidity and mortality in patients with HFrEF, heart failure with a reduced ejection fraction, less than 40%. And now it's considered class 1A recommendation in the new EC guidelines for heart failure. Few pharmacological treatment options are available in patients with heart failure with mildly reduced or preserved ejection fraction. We know that HFpEF represents 50% of patients with heart failure. And we know the data for the use of empagliflozin in heart failure with preserved ejection fraction, which is the EMPEROR preserved trial, which demonstrated that the use of empagliflozin in those patients was associated with reduction in the primary endpoint in terms of cardiovascular death and heart failure hospitalization, but no data at the time for dapagliflozin. So in this trial, the impact of DABA in heart failure with mildly reduced and preserved ejection fraction was studied, looking for the same for the primary endpoint. And interestingly, in this trial, some patients had an improved ejection fraction. They started with an EF less than 40% and received guideline-directed medical therapy, and now the ejection fraction is more than 40%, what's known as heart failure with improved ejection fraction. So this is a new phenotype which have been included in the DELIVER study, which was not included in the EMPEROR preserved trial before. So the study design is very simple, randomized, double-blind, placebo-controlled trial, and the hypothesis is that DABA would reduce cardiovascular death or worsening heart failure event in patients with heart failure with mildly reduced or preserved ejection fraction. So the inclusion criteria: age above 40 years, NIA class 2 to 4, ejection fraction 40% or more, including patients with heart failure and improved ejection fraction, structural heart disease, LVH or left atrial enlargement, high levels of natriuretic peptides, randomization to dapagliflozin 10 milligram once daily, or placebo patients who are not given dapagliflozin. And it was an event-driven trial. The estimated event rate more than 1,000. So the primary endpoint, the time to first composite of cardiovascular death or worsening heart failure. And by worsening heart failure, we mean heart failure hospitalization or urgent heart failure visits. The secondary endpoints: total heart failure events and cardiovascular death, the quality of life estimated by the change in the Kansas City Cardiomyopathy Questionnaire, cardiovascular death, and all-cause death. So this is the flow chart for the study, randomization, patients who were given DABA, 3,131 patients, the same for patients who were given placebo. So 35 sites in 20 countries have been involved in this landmark trial. The baseline characteristics in this slide, we can see that this is heart failure patients, and we know that HFpEF usually old age patients, so the age was 71 years, 43% were females, and the ejection fraction 54%. We have patients with baseline ejection fraction less than 40 and improved now to be more than 40. Ejection fraction less than 60%, which was the majority, 70% of patients. With different NIA function class, the majority function class 2. So if you look for the levels of NT-proBNP in patients with atrial fibrillation, the levels are much higher than compared with patients with sinus rhythm, and the estimated GFR was around 61. GFR less than 60 was reported in around 48% of patients. Different guideline-directed medical therapy and medications were used in those patients, and we can appreciate that the majority were receiving loop diuretics, otherwise ACE inhibitors, ARB, as well as sacubitril valsartan 5%, beta blocker in the majority of 82%, MRA in 42%. What we are looking for what happened for those patients who were given dapagliflozin 10 milligram compared with placebo, and the primary endpoint in terms of the composite of cardiovascular death or worsening heart failure, of course, was much lower The separation of the two curves started earlier. The number needed to treat was 32, a very highly statistically significant p-value in favor for dapagliflozin compared with placebo. And if you look for individually for the components of the primary endpoint, this is for the full population, the 6,000 patients, the same significance, statistically significant difference in the primary endpoint in favor for DAPA. And for patients with ejection fraction less than 60%, the same statistically significant difference in favor for the use of dapagliflozin compared with placebo. If you look for the components of the primary endpoint, the worsening heart failure hospitalization, or urgent heart failure visit, this was statistically significant. But if you look for the cardiovascular death, the p-value was not statistically significant. So the primary endpoint was driven mainly by reduction in heart failure hospitalization. But if you look for sub-analysis, looking for the difference between patients who had an EF less than 60 or EF more than 60%, you can appreciate that the primary composite endpoint was the same. There was no heterogeneity. There was no difference between patients who have baseline EF less than 60 or more than 60. Worsening heart failure, the same for patients with EF less than 60, more than 60. Hospitalization for heart failure, cardiovascular death, as well as all-cause death. So patients who had an EF more than 60% had the same benefit as patients who had an ejection fraction less than 60%. And this is on the contrary to Emperor-Preserved trial. In Emperor-Preserved, as well as in Paragon with the use of sacubitril/valsartan, the benefit of the drug was attenuated with increasing ejection fraction. So with an EF more than 60%, there is attenuation of the benefit of empagliflozin in Emperor-Preserved, and as well as sacubitril/valsartan in Paragon. But in the LEVER study, this is never observed. So the primary endpoint, according to the different ejection fractions, above 40 to 49, 50 to 59, above 60, the same primary endpoint, and as well as the 30 days heart failure hospitalization, and even in patients who had ejection fraction less than 40% and improved, the same primary endpoint significance was achieved with different types of patients. So the primary endpoint in the subgroups, according to the age, gender, race, geographical region, the same benefit also was proved. The secondary endpoints, the total heart failure events and the cardiovascular death, there was also statistically significant difference in favor for the use of dapagliflozin. And the number of events, you can appreciate that the number of events was lower with the use of DAPA compared with placebo. And for any new drug, the impact on quality of life is very important. So in heart failure patients, if you have drugs which improve symptoms and quality of life, this is highly appreciated. So the secondary endpoints in this trial proved also that the use of dapagliflozin was associated with improvement in quality of life, estimated by Kansas City Cardiomyopathy Questionnaire, and this is the impact of COVID-19 on the trial. And for any new drug, the safety issue is very important. So usually with the use of SGLT2 inhibitors, we are looking for any adverse events or serious adverse events leading to discontinuation of the drug. So again, the safety issue of SGLT2 inhibitors was proved in all trials, started by DAPA-HF, Emperor-reduced trial, as well as Emperor-preserved trial. That the use of SGLT2 inhibitor, once daily dose of 10 milligram is very safe and no risk for hypoglycemia, no risk for adverse events or discontinuation of the drug compared with placebo. So the conclusion of this study in the largest and most inclusive trial for heart failure patients with mildly reduced or preserved ejection fraction, treatment with dapagliflozin reduced the risk of primary composite outcome of cardiovascular death or worsening heart failure. Dapagliflozin reduced all components of the composite, total heart failure events, and resulted in improving symptoms burden as assessed by Kansas City Cardiomyopathy Questionnaire. These findings were consistent across pre-specified subgroups, including those who defined according to ejection fraction with no attenuation in the highest EF more than 60%. Dapagliflozin was effective in patients with recent heart failure hospitalization and in those with prior reduced EF that had improved to more than to over 40%. Serious adverse events and adverse events leading to discontinuation of the drug were similar between DAPA and placebo. So these data provide further evidence to support the use of SGLT2 inhibitors as the foundation therapy in patients with heart failure, regardless of care setting or regardless of ejection fraction. So the drug is associated with consistent benefit across different ejection fraction, less than 40, above 40, 50, above 50, and even above 60% in heart failure patients with mildly reduced or preserved ejection fraction. Thank you for your attention.